Speak about diabetes and Staphylococcus aureus bacteremia. I am a former consultant microbiologist and infection specialist at Queen Elizabeth Hospital, Birmingham. Queen Elizabeth Hospital is one of the largest hospitals in the country, and it is a teaching hospital attached to University of Birmingham. And it is a major tertiary referral center in UK and has major transplantation units, including solid transplantation, that is kidney, liver, lungs, heart, and also it has the largest intensive care units in Europe. It provides also other special normal general services like medical, surgical, and burns services. So I graduated originally in 1976 from Orissa, SCB Medical College. And following that, I moved to Delhi and underwent postgraduate training in microbiology in AIMS Delhi, and following that, successfully completing the training program there and obtaining a registrar job for 2 years, I moved to UK with my family. In UK, I pursued my career in microbiology and infectious diseases, and which consists of minimum of 5 years training program, which I successfully completed and obtained the membership exam, that is member of Royal College of Pathologists, following which I was appointed as a consultant microbiologist at this hospital. This Queen Elizabeth Hospital is a part of the University Hospitals Birmingham, which has also other 2 hospitals at different sites. So during my consultant post in this hospital, I in addition to laboratory tasks like authorizing important results, I was actively involved in clinical care of the patients, and I got experience in immunocompromised patients' infections and also intensive care infections. I developed particular interest in infections in immunocompromised patients, particularly fungal infections and other rare infections, rare and serious infections. I developed interest also in cardiac infections, and I set up the cardiac infection service in 2009, and I was the lead cardiac infection specialist since that period until my retirement 18 months ago. So during my post, I also, in addition to providing clinical service, I was actively involved in teaching and training of undergraduate and postgraduate trainees, and also carrying out research, publishing papers, and presenting in national and international meetings. My special interests also included Staph aureus bacteremia in addition to cardiac infections. So this is just a picture of one of the landmarks of Birmingham, showing Birmingham Town Hall, which is an old building set up in 1834, and it hosts several conventions like concerts and meetings and conferences. This is Birmingham Canal navigations. Birmingham is the city with most canals in UK. It has about 100 miles stretch of canals, and these used to be very important during Industrial Revolution, when the heavy goods like coal, iron, and other heavy goods used to be transported through these canals. But since 1980s, that has declined, and it has provided otherwise very recreation facilities along the banks of the canals, several parks and restaurants and clubs have been set up, and it produces recreational and sporting facilities for cyclists and walkers. So diabetes in UK, I'll sort of briefly to give you an idea of problem of diabetes in UK before I go to the actual infection problem. So it is estimated that more than 4.9 million people in UK have diabetes, and the cases have doubled in the last 15 years. And as expected, in most places in the world, 90% are of type 2 diabetes. And it is also estimated 1 in 10 people over 40 in UK have now type 2 diabetes. And as most of you probably know, ethnicity plays an important role in the incidence of diabetes. So in terms of Black Africans and Asians have a greater risk of developing diabetes, particularly at an younger age. So besides the actual incidence of diabetes, it is also estimated that 13.6 million people are now at increased risk of type 2 diabetes in the UK. That means it includes those not diagnosed yet. And NHS spends at least 10 billion pounds per year on diabetes. That is about 10% of its budget, which is quite a high proportion. So I think most of us know that diabetes predisposes to infections. Just to remind us, the immune system, metabolic dysfunction, and hyperglycemia in diabetes, it predisposes to infections. And a variety of infections can develop, starting from skin and soft tissue to bone and joint and respiratory tract infection, etc. The bloodstream infections are estimated as more than two times higher in people with diabetes, that is septicemia or bloodstream infections. So it has been estimated that it is quite high in patients with diabetes who are admitted to hospital. And patients with diabetes also tend to be hospitalized more frequently, about 2 to 3 times higher than patients without infections. So infection is a big problem in them. And also, not only just admission, they also have high rate of mortality, which has been shown in some studies, but not in others. So this is Staph aureus. Just to remind us, it's a gram staining of appearance of Staph aureus, which are purple color and arranged. They are arranged in like grape-like fashion. So it is part of normal flora, which means we do carry them without developing any disease. So 30% of healthy persons are colonized. And this rate of colonization is higher in people with insulin-dependent diabetes, people with skin damage, and those undergoing dialysis and HIV infections. So what's the pathogenicity of Staph aureus? Why it is so important? And how does it differ from other organisms? So it is one of the most pathogenic bacteria causing human infections, both in the community and hospital. So it has a unique ability to adapt and survive in a variety of environmental conditions. It produces a battery of surface adhesins like proteins, enzymes, and toxins, which cause the disease more effectively. So Staph aureus has evolved also with additional acquisition of additional genes, which are glucose transporter genes, which are of advantage to them in comparison to other bacteria, so that they can multiply quickly in presence of excess blood sugar. So important characteristics of Staph aureus infections are, just to summarize in brief, rapid tissue invasion, propensity to cause deep-seated infections, for example, in spleen, liver, paraspinal abscess, and septic arthritis, things like that. Rapid dissemination from original focus. So from the focus of infection, it can disseminate to various parts of the body, producing metastatic infections at distant sites. A patient with a foot abscess subsequently may develop endocarditis, or paraspinal abscess, mediastinitis, so on. And also important characteristics of this bacteria from other bacteria is that it has propensity to cause persistent and recurrent infections through intracellular survival and biofilm formation. Biofilm is a matrix of bacteria and cellular cells which can form easily on devices, particularly medical devices, IV lines, prosthetic bone and joint material, and also in the heart valves. So that itself causes very difficulty in eradicating the bacteria because the antibiotics have poor penetrations into the matrix. So the mechanism of infections broadly are by direct invasion or toxin mediated. There are several toxins that are produced, like staphylococcal toxic shock syndrome, staphylococcal scalded skin syndrome, PVL toxin, which are Panton-Valentine toxin and enterotoxin. So these can produce systemic effects without the staphylococcus disseminating throughout the body. And as all of us probably know, most common cause of skin and soft tissue infection. So the infection can be with superficial infections to deep-seated and serious infections. The risk of invasive Staph aureus infections increases in diabetes. That has been shown in various reports and has been observed. The clinical features in patients with diabetes are essentially the same as in people without diabetes. So how do you define what is Staph aureus bacteremia? Staph aureus bacteremia is defined as isolation of Staph aureus from at least one blood culture with general clinical features of infection. So the incidence of Staph aureus bacteremia has been estimated and reported to be increasing worldwide. It is one of the most common of serious bacterial infections. It is also currently the most common cause of bacterial endocarditis. Staph aureus bacteremia is a major cause of community-acquired and hospital-acquired bacteremia, and it is more common in male and higher age groups, that is over 65. It has a high morbidity and mortality of around 20 to 40%. And the mortality is higher in resistant strains. As you may know, the methicillin-resistant strain, which is in short form or MRSA, are prevalent in many parts of the world. And fortunately, the incidence of MRSA is low at the moment in UK. So the mortality is higher in these resistant groups, in MRSA groups, rather than MSSA, which is the methicillin-sensitive Staph aureus. The complication of Staph aureus bacteremia, such as continuing fever, persistent bacteremia, in spite of antibiotics, and recurrent bacteremia, endocarditis, and metastatic deep tissue infections are common in Staph aureus bacteremia. So in a large study by Fowler et al., who is one of the leading authority in Staph aureus bacteremia, he showed that reported in 2003 that in 724 patients, the observation was 43% had complicated Staph aureus bacteremia. Most studies around roughly report about 1/3, 30% of people developing complications. And in his studies, endocarditis was in the top of the list among complications. Among the complications, it comprised 39%, besides others like septic arthritis, deep tissue abscess, vertebral osteomyelitis, in that decreasing order. And there were some other complications in smaller percentages. So the complications are very important and common. And they reported that infectious disease specialist consultation results in a better outcome. So these are all studies in the hospital, in a hospital setting. Complicated Staph aureus bacteremia definitions. How do you define complicated Staph aureus bacteremia? Number one is positive follow-up blood culture while on appropriate antibiotics. Continued fever after 48 hours of appropriate antibiotics. Number 3, endocarditis, if it is diagnosed according to the modified Duke criteria. Number 4 is evidence of metastatic or deep tissue infections. Number 5, presence of indwelling devices such as prosthetic heart valves, pacemaker, defibrillator, or vascular graft. So basically, most studies have agreed with these definitions because this definition is important to stratify Staph aureus bacteremia because the management will be tailored accordingly. So this is in 2 patients, just to show about the complications Staph aureus bacteremia can cause. This is the imaging of MRI spine of a patient with type 2 diabetes who presented with back pain and fever. So on physical examination and from the history, the spinal infection was suspected and MRI scan showed thoracic spine involvement and a large paraspinal abscess. This patient had presented with sepsis and Staph aureus was isolated from blood culture, but the first transesophageal echocardiogram did not reveal any vegetation. Patient completed antibiotic therapy, went home, then returned 2 months later with fever and sepsis, and Staph aureus was isolated again from blood culture, and a repeat TOE showed a vegetation on one of the cardiac valves. So endocarditis was diagnosed and was appropriately treated. So what's the Staph aureus bacteremia at Queen Elizabeth Hospital where I worked? So when I saw the Staph aureus bacteremia was causing so much havoc, I started a study in 2000 for over a 14-month period and found 139 cases, and in which at the time, MRSA bacteremia was quite prevalent, and that comprised about 60% of all Staph aureus bacteremia, and the mortality was quite high in MRSA bacteremia as opposed to sensitive Staph aureus bacteremia. Endocarditis were diagnosed in 5%. Subsequently, I did study also with my team, and that was only on MRSA bacteremia, where again the mortality was quite high. And most recently, we did a study in our hospital over a 14-month period, and we wanted to know whether endocarditis can be diagnosed more effectively by doing TOE on all patients. And when that policy was followed, the incidence of endocarditis we detected was 16%. So what's the Staph aureus bacteremia situation in England? We have mandatory surveillance undertaken by Public Health England, and that commenced from 2011, along with E. coli bacteremia surveillance. So quarterly data is collected from all laboratory, and all hospital laboratories are legally bound to report cases of E. coli and Staph aureus bacteremia. So from the latest financial year, that is April 20 to March 21, 11,609 cases were detected, which is a rate of 21 per 100,000 population. So that was a rate of Staph aureus bacteremia as a total. And sensitive Staph aureus comprised actually the most of the Staph aureus, and that was found to increase. An increase of 33% from start of surveillance, which was from 2011. And MRSA bacteremia, fortunately, the incidence is much lower, 1.2 per 100,000, as opposed to 21 in sensitive Staph aureus. And MRSA bacteremia, just to remind us, was a big problem 20 years ago in UK, in our hospital as well. But with effective infection control program, that infection rate of MRSA has decreased substantially. So in the PHE surveillance, they found 72% are community acquired. So it is quite important to know that it develops in the community, and they present obviously when they are very ill, they are admitted to hospital. And so higher incidence in male and older age groups, which have been reported before, and they found also skin and soft tissue infections, the predominant source, followed by IV line and pneumonia. And in the study, the 30-day mortality was 20%, as roughly we also found in our hospital, and MRSA bacteremia was associated with increased mortality. So this is just a graph to show the PHE surveillance, how the Staph aureus bacteremia, sensitive Staph aureus bacteremia has increased with a slight decrease when the COVID came up, maybe because of the cancellation of routine operations, decreased admissions of other patients, and following that, it has increased back again. What's the recommendation for Staph aureus bacteremia management? So all patients with Staph aureus bacteremia should have a clinical bedside initial review by an infection service, prompt removal and drainage of focus of infection or collections, and daily subsequent. This is very important because if the source is not removed, then the bacteremia will continue. And the importance of bedside initial review is to detect what could be the focus of infection by careful history, by careful examination of the patient. For example, a patient with a Staph aureus bacteremia and a back pain, one would think about or exclude vertebral infection or paraspinal abscess. A patient with abdominal pain, Staph aureus bacteremia, one could think about splenic emboli, or with a stroke, whether it is cerebral emboli. So the history and examination is very important. Daily subsequent review to assess clinical resolution is very important because very frequently, when the patient presents with Staph aureus bacteremia, the complications are not obvious. So that can develop subsequently. So that's why daily examination is very important. And repeat blood culture after 2 to 3 days of antibiotic is important because if Staph aureus grows from repeat blood cultures after starting antibiotics, it is an indication that it is complicated bacteremia and the source has to be detected, and antibiotic management has to be tailored differently with a prolonged duration. So high complications of Staph aureus bacteremia, such as infective endocarditis and vertebral osteomyelitis, are common, as I already said, difficult to identify initially. High index of suspicion is required to detect the complications. Failure to identify such complications may lead to persistent or relapsing bacteremia or catastrophic outcomes. Echo is recommended for all cases of Staph aureus bacteremia, whereas non-cardiac imaging, such as CT of spine or MRI of head or CT of abdomen, they can be tailored to patients with compatible clinical features, as I have already discussed. So what antibiotics is recommended for Staph aureus bacteremia? As for Staph aureus infections, flucloxacillin is the drug of choice, and intravenous flucloxacillin is recommended for Staph aureus bacteremia, unless there is penicillin allergy, where vancomycin or other approved non-penicillin group of antibiotics for patients with penicillin allergy, or if MRSA, because MRSAs are not covered by flucloxacillin by definition. How long do you treat Staph aureus bacteremia? It's recommended a 2 week of antibiotic for uncomplicated Staph aureus bacteremia. Uncomplicated are those which are not included, do not show the features of complicated bacteremia, basically. And in complicated bacteremia, the therapy is at least 4 to 6 weeks of antibiotics. Diabetes and community-acquired Staph aureus bacteremia. In a very interesting study recently from 2016, over 2,638 patients in a Danish study showed that Staph aureus bacteremia acquired in the community is 3-fold higher in incidence than matched control population, in other words, without diabetes. And the risk of community-acquired Staph aureus bacteremia is 7 times higher in patients with type 1 diabetes. So that's quite an interesting result. And they also identified poor glycemic control, diabetic complications, particularly with microvascular disease, that is renal disease or diabetic foot ulcers, and diabetes of long duration are associated with increased risk of community-acquired Staph aureus bacteremia. So diabetes and invasive Staph aureus infections, including bacteremia and endocarditis, are common, and diabetes is a risk factor for these infections. They are more likely than non-diabetics to have endocarditis and complications. Mortality rate has been reported previously significantly higher among diabetic patients with bacteremia, with Staph aureus than non-diabetic patients in some studies. So in conclusion, Staph aureus bacteremia is a serious medical condition, particularly in people with diabetes. Clinicians should have awareness of Staph aureus bacteremia, its risk factors, and complications. As most cases are community-acquired, focus of interventions needs to include Staph aureus infections right in the community. Thank you very much.